Hello and welcome back to the CMR Webinar series. My name is Valentina Puntman and I would like to welcome you to the part 2 on the role of CMR in hypertrophic cardiac conditions. The focus of this webinar is on hypertrophic cardiomyopathy, which is the commonest hereditary condition presenting with hypertrophic phenotype. For the major part of this webinar, we will be guided by the recent ESC statement on diagnosis and management of hypertrophic cardiomyopathy. A number of causes underlie this condition. The commonest include inherited gene mutations, encoding a number of myocardial sarcomeric proteins. Hypertrophic cardiomyopathy is broadly defined by the presence of increased left ventricular wall thickness that is not solely explained by abnormal loading conditions. The major diagnostic criterion in an adult patient is the finding of left ventricular wall thickness of equal or more than 15 mm in one or more myocardial segments. In a first-degree relatives, left ventricular wall thickness of equal or more than 13 mm may suffice for diagnosis. Although not pathognomonic, additional phenotypic features include myocardial fibrosis, morphological abnormalities of the mitral valve apparatus, abnormal coronary microcirculation, as well as ECG abnormalities. The current practice guidelines foresee an important role for cardiovascular magnetic resonance in evaluation of patients with hypertrophic cardiomyopathy, primarily as reliable means for confirmation of the diagnosis, by way of detailed assessment of cardiac function and structure and non-invasive assessment of myocardial fibrosis. In hypertrophic cardiomyopathy, the phenotypic presentation can be hugely diverse, and yet it may be broadly subdivided into major groups, characterized by either predominant septal or apical hypertrophy, as also shown in these two typical cases. In establishing the diagnosis, maximal left ventricular wall thickness counts as the single most relevant parameter. It is obtained by measuring left ventricular wall thickness in three standardized short-axis slices, that is, basal, midventricular, and apical slice. It is most intuitively presented in a 16-segment HA model, allowing an immediate recognition of the leading morphological features, such as predominant septal hypertrophy compared to stronger apical weighing. Cardiac magnetic resonance can be also helpful with visualization of flow acceleration and flow obstruction phenomena, which most commonly affect the area of left ventricular outflow tract. Flow acceleration consequently affects the function of mitral valve by pulling the anterior mitral valve leaflet into the area of flow acceleration within the LVOT. Displacement of mitral valve leaflet happens right in the middle of systole, that is, at the time when mitral valve is supposed to be shut. The valve function is consequently impaired, as evident by the presence of an eccentric, posteriorly oriented regurgitant jet. LVOT obstruction is considered present when LVOT flow velocity exceeds 2.7 meters per second, whereas hemodynamically relevant, that is, responsible for the symptoms, when flow velocity exceeds 3.5 meters per second, at which point treatment of LVOT obstruction may be considered. Hypertrophic cardiomyopathy is characterized by complex underlying histopathology, including myocardial disarray, microvascular disease, and myocardial fibrosis. Myocardial fibrosis in hypertrophic cardiomyopathy is of two types. Regional replacement fibrosis can be visualized with late gadolinium enhancement, whereas diffuse interstitial fibrosis can be detected by means of T1 mapping. Replacement fibrosis can be visualized in about 60% of patients with hypertrophic cardiomyopathy as bright intramyocardial, non-ischemic hyperenhancement. Assessment of diffuse myocardial disease, including accumulation of interstitial myocardial fibrosis, represents a challenge for late gadolinium enhancement. Assessment of diffuse myocardial disease is now amenable by means of quantitative tissue characterization techniques such as T1 mapping. Ourselves and other groups have shown that T1 mapping values, including native T1 and ECV, are markedly raised in patients with hypertrophic cardiomyopathy compared to controls. There is a linear relationship between T1 values outside the area of late gadolinium enhancement and myocardial collagen content. Myocardial fibrosis is an early manifestation in development of hypertrophic cardiomyopathy and detectable in gene mutation carriers with sub-expressed hypertrophic phenotypes by evidence of increased serological markers of collagen metabolism as well as T1 mapping indices, including extracellular volume fraction and native T1. Hypertrophic cardiomyopathy is associated with an increased risk of cardiovascular death. The sudden and unexpected nature of these events in apparently healthy young people provides a compelling argument for search of predictors that would help to identify those at risk and prevent such events. The current guidelines foresee 8 major clinical features which have been established as valid predictors in a large observational longitudinal multicenter study. Although not assessed directly, the 2 imaging markers among the predictors can be also obtained with cardiovascular magnetic resonance. Several studies have shown that the severity and the extent of left ventricular hypertrophy are associated with the risk of sudden death in patients with hypertrophic cardiomyopathy. This risk is particularly pronounced with maximal left ventricular wall thickness of more than 30 millimeters. Several studies have also revealed that there is a significant trend towards worse survival with increasing LVOT flow acceleration and flow obstruction. Prognostic significance of replacement fibrosis visualized by late gadolinium enhancement has been also examined in several studies. A meta-analysis of pooled data revealed that the presence of late gadolinium enhancement relates to cardiac, heart failure, and all-cause mortality. However, it is not predictive of sudden cardiac death. These findings form the basis of a recommendation statement, which acknowledges the utility of late gadolinium enhancement imaging in prediction of cardiovascular mortality, however not in prediction of risk of sudden cardiac death. A more recent study examining the largest cohort with cardiovascular magnetic resonance to date emphasized the role of standardized quantitative analysis of late gadolinium enhancement, measured as a percentage of the total myocardial mass. This study revealed a significant increase in risk of sudden cardiac death per every 10% increase in late gadolinium enhancement. The findings of this study potentially provide a methodological fine-tuning and a step forward for late gadolinium enhancement in prediction of sudden cardiac death. And last but not least, late gadolinium enhancement can be extremely helpful in differential diagnosis of left ventricular hypertrophy due to amyloidosis. This is based on a pathognomonic pattern of late gadolinium enhancement in amyloidosis, revealing black blood against black myocardium and some patchy intramyocardial enhancement. In summary, we've looked at the definition and causes underlying the development of hypertrophic cardiomyopathy. We have clarified diagnostic criteria based on the measurement of maximal left ventricular wall thickness, as well as reviewed the associated features, including left ventricular outflow tract obstruction, as well as myocardial fibrosis. And lastly, we've discussed the role of imaging measures in prediction of risk for sudden cardiac death in patients with hypertrophic cardiomyopathy. And here is the list of literature that I have used in preparation of today's webinar. I hope you've enjoyed this webinar, and with this I would like to thank you for your attention.